Welcome to the Defeating Epilepsy Foundation YouTube channel. In this presentation, we will discuss what stereotactic radiosurgery is, how it is used, side effects, what happens before, during, and after the procedure, complications, benefits, equipment used, and how the procedure is performed. Make sure to like our videos and subscribe to our YouTube channel. Click on the bell to be notified of future videos. Please click on our donate link in the description section below and donate today. Your donation helps us to make a difference for those battling epilepsy. We appreciate your support. Stereotactic radiosurgery is a very precise form of therapeutic radiation that can be used to treat abnormalities in the brain and spine, including cancer, epilepsy, trigeminal neuralgia, and arteriovenous malformations. It was conceived by a team of neurosurgeons and physicists in Sweden about 50 years ago to deliver radiation to precise targets in the brain while minimizing injury to adjacent areas. SRS works by distorting and destroying the DNA of tumor cells. As a result, these cells lose their ability to reproduce and die. Stereotactic radiosurgery uses sophisticated 3D computerized imaging to precisely focus photon beams, delivering a highly concentrated dose of radiation to a precise target in a single session. It carefully aims beams of X-rays at abnormal tissues through the skin from multiple directions. The X-ray beams distort or destroy the DNA of cells in abnormal areas so they are unable to reproduce and grow. Abnormal tissue becomes inactive and gradually shrinks. With optimal treatment, the abnormal tissue becomes inactive and gradually shrinks. The principles of stereotactic radiosurgery, namely high precision radiation where delivery is accurate within 1 to 2 millimeters, are now being applied to the treatment of body tumors with a procedure known as stereotactic body radiotherapy. Both rely on several technologies such as image-guided radiation therapy, which uses medical imaging to confirm the location of a tumor immediately before and in some cases during the delivery of radiation. Stereotactic radiosurgery and stereotactic body radiotherapy are important alternatives to surgery, especially for patients who are unable to undergo surgery for tumors and abnormalities that are hard to reach, located close to vital organs, and subject to movement within the body. The following side effects are typically temporary and get better within a few weeks: fatigue, skin irritation at the treatment site, hair loss at the treatment site, headache, neurological symptoms such as seizure, numbness, tingling, or weakness, hair loss in the treatment area, mouth problems and difficulty swallowing, eating and digestion problems, diarrhea, nausea and vomiting, headaches, soreness, and swelling in the treatment area. Stereotactic radiosurgery takes a team approach involving specialists in radiation oncology and neurosurgery. A dosimetry expert determines how the beams should be directed, and a physicist calculates the amount of radiation the patient should receive, balancing risk and potential effectiveness. A CT scan is obtained with contrast administration and is then merged or fused with an MRI of the brain, which is usually obtained before the procedure. The CT complements the MRI, and together the two studies improve the accuracy of the procedure. A key element of planning the procedure is maximizing the treatment of abnormal tissues while protecting healthy tissues around the abnormal area. Steroid medication in the form of Decadron may be administered before the procedure and then continued for a brief time following the procedure. Sometimes a person suffers from claustrophobia. Local anesthetic is administered, and the frame is secured to the skull by 4 sterile pins. The only discomfort is during the administration of the local anesthetic. One exception is that some patients who are having treatments to the brain may see flashes of light while the machine is on, even with their eyes closed. When the head frame is removed, there may be some minor bleeding from the pin sites that will be bandaged. In most cases, radiosurgery and SBRT patients can resume all of their normal activities within 1 to 2 days. Complications from radiosurgery are few, such as pin site bleeding or infection is rare, and swelling around a tumor may occur, which is why Decadron is administered. In rare instances, a seizure may occur. These are generally brief and self-limiting. One late complication that may be seen is known as radiation necrosis. Tumor cell led by radiation, but inadequately cleared by the body. In some instances, this can cause further brain swelling requiring an additional or increased dose of Decadron. In refractory causes, hyperbaric oxygen may be administered or surgery considered to remove dead tissue. This is why it is important to have close follow-up with a neurosurgeon or radiation oncologist. It is also possible for a tumor to recur in a different part of the brain, as SRS only targets a very focal area. In such instances, the SRS treatment may be repeated on the new areas of tumor growth. Due to limitations imposed by the overlap of radiation beams coming in from different directions, it is generally recommended to limit the number of tumors treated in one session to 4. At some centers, patients who have Parkinson's disease, epilepsy, or some form of psychoneurosis such as obsessive compulsive disorder may be treated on an experimental basis with stereotactic radiosurgery. More recently, with the advent of frameless techniques, stereotactic radiosurgery is being used for spine lesions, more frequently metastatic lesions, and less often benign spine tumors. This technology makes it possible for neurosurgeons to reach the deepest recesses of the brain and correct disorders not treatable with conventional surgery. Since there is no incision, there are minimal surgical risk and little discomfort. Adult patients may be lightly sedated but are awake throughout the procedure. Hospitalization is short and at most requires an overnight stay. Most patients are treated on an outpatient basis. As a result, patients experience less discomfort and have much shorter recovery periods than having undergone conventional surgery. The Gamma knife uses 192 or 201 beams of highly focused gamma rays, all aiming at the target region. The Gamma knife is ideal for treating small to medium-sized intracranial lesions. Linear accelerator machines, prevalent throughout the world, deliver high-energy X-rays, also known as photons. The linear accelerator can perform SRS on larger tumors in a single session or during multiple sessions, which is called fractionated stereotactic radiotherapy. Proton beam or heavy charge particle radiosurgery is in limited use in North America, though the number of centers offering proton therapy has increased dramatically in the last several years. Stereotactic radiosurgery using the Gamma knife. Gamma knife radiosurgery involves 4 phases: placement of the head frame, imaging of the tumor location, computerized dose planning, and radiation delivery. In the first phase, a nurse will place a small needle in your hand or arm to give you medications and contrast if needed for imaging. A neurosurgeon will use local anesthesia to numb 2 spots on your forehead and 2 spots on the back of your head. A box-shaped head frame will be attached to your skull using specialty designed pins to keep your head from moving within the frame until the treatment session is finished. This lightweight aluminum head frame is also a guiding device that makes sure the gamma knife beams are focused exactly where the treatment is needed. Next, you'll be taken to an imaging area where an MRI scan will be performed to show the exact location of the tumor in relation to the head frame. In some cases, a CT scan may be performed instead of or in addition to an MRI scan. Radiosurgery using the linear accelerator SRS is similar to the gamma knife procedure and has its 4 phases: head frame placement, imaging, computerized dose planning, and radiation delivery. LINAC technology is much more common than gamma knife technology. Unlike the gamma knife, which remains motionless during the procedure, part of the LINAC machine, called a gantry, rotates around the patient, delivering the radiation beams from different angles. When SRS is delivered using CyberKnife, a robotic arm moves the compact LINAC around the patient under image guidance. SBRT. For some technologies like the CyberKnife that base image guidance according to an X-ray based solution, you may be asked to have a fiducial marker placed in or near your tumor for selected cases. Placement of the fiducial marker is almost always an outpatient procedure. Next, the radiation oncologist will determine the methods of aligning your body with the beams from the linear accelerator, which is called a stimulation. Immobilization devices are often used to align patients very precisely and make sure they remain still during stimulation and treatment. After an immobilization device is created for you, a CT scan is performed over the area to be treated. Physicians may also perform a 4D-CT, where the CT scan obtains information on how your tumor moves while you breathe. This is very common for tumors in the lungs or liver. The third part of the course is planning. The radiation oncologist will work with a radiation dosimetrist and medical physicist to plan the beam arrangement best suited for your tumor. They may incorporate other imaging techniques such as MRI or PET/CT. Radiation delivery of SBRT is done on the linear accelerator. To learn more about stereotactic radiosurgery, please check out the resources used in the presentation today. Please like and subscribe to our YouTube channel and follow us on our social media pages. We would love to hear from you. Leave a comment below or email us at info@defeatingepilepsy.org. Thank you for your support, and together we will defeat epilepsy. Check out our other great videos and subscribe today. You have the power to defeat epilepsy.